So, a very good evening to all of you. It's indeed another very much awaited WinCars interventional meet. And I have with me the president and the chair of WinCars, Dr. Sarita Rao and Dr. Sujata Viparla, who extend a very warm welcome to all of you. And of course, we have the pillars of our WinCars in the form of Dr. Asha Mahilamaran, who is today going to present a real, very interesting case where ECMO was used in the patient who had probably an acute coronary event. And let's see how the story unfolds. So, Dr. Rupali and Dr. Priya are also there who have joined in us for the panel discussion. So, all over to Dr. Asha Mailamaran, not coming between you and the very interesting case. Here we go. Dr. Asha, I would also request you to introduce the guest faculty who are there with us and who are going to take us as the story unfolds.
Yeah, absolutely. This was a very challenging patient where a team multidisciplinary approach helped get him out of the hospital, walking back home. And we would like to share this case with you and how we go about in future cases like this. We can come to a consensus as well. It was an ECMO supported left main PCI. He had a very stormy beginning. I was on call, and in Apollo, we stayed back in the hospital during call days. And this was a 47-year-old gentleman who was a known diabetic for 10 years duration, hypertension of 10 years duration. He presented to the emergency department with acute onset breathlessness. He had some chest pain about 5 days back, no ongoing pain. He was more breathless and gasping, literally. His blood pressure was 190/90, heart rate was 130 per minute. He was in frank acute pulmonary edema. His troponin was positive at 1.92. BNP was elevated 555. His echo was EF was 30%. It was extremely bad LV. Mid anterior septum, apex, anterolateral wall was akinetic. Most of it was akinetic. The apex was dyskinetic. He was intubated in the ER on FiO2 100%. His pH was 7.057. His PO2 was 69 millimeter mercury. His lactates initial was 2.2. It worsened over time, and his PO2 also kept worsening over time. He was intubated around 1:30 a.m. in the morning. So the decision was to stabilize him and then take him up for a coronary angiogram. But early morning, when I went for the rounds, the initial blood parameters, the hemoglobin was 16.3 grams per dl and his total count was 19.25. Platelets were okay. His urea was 38, creatinine well elevated, HbA1c of 8 and SgO2 of 49. But over time, his saturation was not holding. Just 4 to 5 hours later, when I went early in the morning for the rounds, his saturation was dipping on FiO2 100%. It was only maintaining around 85 to 75, 75 to 85. So this moment, I realized that this patient is not going to hold on for long like this. So we need to involve the multidisciplinary approach needs to be called in. So we initially handled it in the coronary care unit. We called the critical care group who managed more of the respiratory issues as well. So the critical care group were called in. So they analyzed as well initially. So this was the initial ECG. An acute anterior wall MI was there with sinus tachycardia and left atrial enlargement. Patient had pedal edema as well. So he had gone into overt failure. So in fact, he was running around in the hospital for 2 days, meeting gastroenterologists, saying that he had constipation. And before anything, he approached the cardiologist in this situation. He was just going in the OPD. He had accompanied another person, and they were all together doing their own OPD workups. And this was his initial echocardiogram. Except for the basal segments, nothing else was contracting. It was all dyskinetic and extremely sick looking LV. So only the posterior segment can be seen to be contracting. None of the other segments were contracting. And the next day morning, this was kind of his ECG. He had gone into a broad QRS rhythm. and extremely unstable. He was going down, very worsening cardiogenic shock, and this was his X-ray. Absolute frank pulmonary edema after injection of Lasix, ventilation, and also being on maximal FiO2. So at this point, we can either take him up for an angiogram because with saturations not holding, the critical catein said with a prone ventilation is not possible in this condition. So we decided to call the ECMO team at this point of time. And by the time the family took the decision, initially only his wife was there. The family flew in from Guwahati, Assam. So we had to wait for them to arrive. As soon as the family arrived, the discussions happened about ECMO, and the family agreed to ECMO. So by this time, his pressures had dropped, his saturation had dipped to 65%, and he was on 3 inotropes at this point of time. So the emergency, the cardio team, the acute coronary care team, the critical care group, the ECMO team, the pulmonologist input, the infectious diseases input were all obtained before this decision was taken. So the next day morning, the lungs were beginning to clear, but because of the uh, high peak settings, the patient had developed a right pneumothorax. So this was detected in the morning. So an ICD was placed. Otherwise, the plan was to take him up for an angiogram on that day. Because of this complication, we just waited for another 12 hours for the patient to settle, and then took him up the next day. CAG was done through the right radial route. They had a arterial cannula earlier itself, so we just placed through that the wire and exchanged it to a 7 French sheath. I'll just show initially the IVS run, then I will try to fix the angiogram. So the it showed a critical LM and with a diffuse disease extending up to the LM to the mid LAD, and you can see a calcific lesion, but not very circumferential, around 180, and in some parts it was even close to 360 degrees. Calcium, a fibrocalcific lesion was present. So we wired both the LCX and the LCX and the LAD. And it was a single stent strategy from LM to LAD. So it was there was after placing 2 stents, there was a distal stent which was 2.5 into 28 and a proximal stent 3 into 23, and we blew it up, covered up to the ostium, and expanded it with a 4 into 8 NC balloon. After that, we saw a slight stent fracture was also seen, which was patched up with a 3.5 into 12 stent. Then finally, there was a TIMI3 flow and good diameters. And LM we got 14, and in the proximal LED 6.9, and in the mid LED 6.1. And immediately after the post PCI, he went into again pulmonary edema, and subsequently his chest cleared very well, and at this point of time he was taken up for a decannulation. After this X-ray chest, it was planned for a decannulation on the 6th day, and this was the post PCI echo. You can see that the segments, the lateral segments, the mid anterior septum are all beginning to recover. So it started recovering well, and his urea creatinine at the time of procedure, it was 84 2.4. It settled down to 47 1.7, and his EF improved to 40%. He walked into the chamber. Arni, bisoprolol, torsemide, eplerenone, ticagrelor, aspirin, and rosuvastatin were given. And this was the sequence. Day 1, ventilator, not holding saturation, severe acidosis, worsening shock, modes, and VAV ECMO was initiated. Day 2, pneumothorax. Day 3, PCI to LM. Day 4, stable lungs clearing. Day 5, downgrading to VVA ECMO. Day 7, decannulated. Day 8, extubated. Day 9, shifted to ward. Day 10, discharged. Day 12, he was readmitted with slight cough. For safety sake, he was readmitted, and then OMT for heart failure, reduced ejection fraction was initiated, and then he was discharged on all 4 drugs: SGLT2, ARNI, eplerenone, and beta blockers. And then finally, today morning, he had a video consult from home, comfortably sitting in his living room. Urea 32, creat 1.6, is moving around the house comfortably, and he wants to actually start doing yoga and everything. So what I will do is I'll just stop sharing and then just try for the angiograms again. Let me just try for the angiogram. Meanwhile, Madan can present. So I will
Yeah.
just try for the angiograms meanwhile.
Sure.
Yeah.
My colleague Dr. Yashwant is there. He'll be presenting the slides.
Good evening, everyone.
Dr.
My
Yashwant,
name is
please share the slides.
yes. Can you see my slides, sir?
Yeah, we can see. A little bit louder, please.
Yes, sir. Good evening, everyone. My name is Dr. Ashwant. I am a CTVS resident in Apollo, Chennai. I am presenting VA ECMO and post-MI cardiogenic shock, only the ECMO course. I am from heart and lung transplant and mechanical circulatory device team, Apollo, Chennai. The same patient, before ECMO initiation, he was on very high triple inotropic supports. Despite being on high ventilator support with the maximum oxygen, the FiO2 of 100%, he was saturating only 75%. The ABG was showing severe metabolic acidosis with the lactates of 10.33 millimoles per liter. Proning was denied to maintain the saturation. It was denied in view of very high triple inotropic supports. And he was heading into multi-organ failure, especially liver and kidney injuries were seen. Before ECMO initiation, the ABG was showing like severe metabolic acidosis with high lactate levels and normal PO2s. This is with the FiO2 of 100% with the high ventilatory settings. Before initiation, the echo of the before initiation, it was showing a moderately severe LV dysfunction. Short axis parastart. Decision during ECMO for the ECMO, after extensive discussion with the multidisciplinary team and patient's family, we had initiated VA ECMO at bedside with the percutaneous technique. Here, ECMO was considered as a bridge to decision making because we don't know the multi-organ dysfunction will recover, or we are not sure where we what we have to proceed. So we thought it was a decision making, either to revascularize or what to do next. So this was just displayed only 2 cannulas. This was the venous dryness cannula in the femoral vein, and this was the returning cannula for the femoral artery, and this was distal perfusion cannula for the leg. And this is, everything was inserted in percutaneous technique. These reasons for weak ECMO configuration. We had selected arterial cannula, A returning cannula, because he is on very high inotropic supports to maintain the blood pressures. B returning cannula, he was desaturating, so we had decided to go with B AV ECMO. It's tissue perfusion achieved. Yes, we had achieved. The immediately after initiating ECMO day 1 or day 2, acidosis was settling, lactates was in decreasing trend, PO2 levels were improving, and liver and renal functions were also improving. This was a serial of ABGs before ECMO day and during ECMO and on the 5th day of the ECMO. We can see that decreasing trend of the lactates. It came even less than 1 in the day of the 5th day of the ECMO, and the acidosis was also settling. We had considered a revascularization on the day 2 of the ECMO. Angio was done by Asha ma'am. It was left main and triple vessel disease. Left main with the LAD stenting was done. This was the angio peak. I just started just 2 peaks before stenting and after stenting. Events during ECMO. In day 2 he had developed right side spontaneous pneumothorax, and we had inserted ICD on the same day. And at day 3 he had leukocytosis, increase of inotropic supports. So we thought it may be due to some systemic infection is going on. So we had involved an infection specialist to cover both the gram positive, gram negative, and atypical microorganisms. Even though the blood cultures were showed, so no growth. X-ray was showing there was right on the day 3, day 4. X-ray was showing right upper lobe opacity. So we did bronchoscopy. On the bronchoscopy, we had seen right upper lobe there was secretions was seen, and we saw suctioning was done, and the ball was sent for bacteriology. It was showing scanty growth of coagulous negative staphylococcus. The same antibiotics have been continued. Then he started to show some improvement with decreasing on inotropes. The inotropes was weaned and stopped. Leukocytosis were decreased, and there was improvement in the GCS and other organ functions. So we had considered weaning from ECMO. In view of almost there was nil inotropic supports, improvement of liver, renal, and even heart functions. There was improvement of GCS with the decreasing oxygen requirement. Then we had first step we had did was VA ECMO was de-escalated into VV ECMO. Then we had decreased the flow to 1 liter. For 24 hours we had maintained 1 liter, and we were able to maintain his blood pressures and oxygen. So we proceeded with the decannulation on the following day. Decannulation was done in the OT in the open technique. We had this was the proximal cannula, this was the distal cannula. Both cannulas were exposed, and we had removed both cannulas. There was a big clot in the femoral artery, which was removed using Fogarty. Even though we were anticoagulated him, and pulses were present, there was a clot and it was removed using Fogarty. After decannulation, the ABG was showing improvement. It was pH of 7.4, PCO2 29, and even PO2 levels are 140, lactates are 1.19. This was echo after ECMO decannulation and after revascularization. There was improvement in the EF from 35 to 45. Conclusion: he was discharged in a stable condition without any disability. He was advised to be in the follow-up. On-time ECMO initiation can prevent multi-organ failure, and early weaning. It will help early weaning also.
Thanks, Ashwin.
Yeah, thank you,
There
Madan.
are 3 main important points we need to.
I'll
What
just
is
share
it?
the slides of the angio, and then we can have
Okay.
the discussion.
Sure.
Now it's opening, so I will just start. I think you have to enable my share screen.
Yashwant,
Kumar?
you have to do the stop sharing.
Yes, yes, sir.
Yeah, I will just start from the. So it's visible.
No,
No, ma'am.
Can you see?
no, I'm not able to
No?
see.
It's not seen.
Children, you have to start sharing again. Your screen is still
I'll
not
do
shared.
that only. The sharing.
Nothing.
Now,
Yes, we can see your slides. Yes, sir.
yeah. So this was the initial angiogram, looking pretty scary. But the comfort was the patient was on ECMO, and so pretty diffuse and thinned out distal vessel of LAD. So the plan was to go up to the after the IVAS. We confirmed that there was some uh, reasonable spot after the second diagonal. So plan to stop the stent after the second diagonal. The right coronary artery has a lesion with about 75-80%, both in the proximal and in the PLV. So the plan is to call him back after 3 months for a staged revascularization, and at that time we can check the left main as well. So wired both the LCX and the LED. The plan was to keep the LCX flowing and stent from first the distal LED and then from the proximal LED up to the ostial LM. So that was a plan. So went with 2 into 12 NC balloon at first, and then serially dilated it. And this was the outcome after that. Uh, then subsequently with a 2.5 into 12 NC. Uh, and every time we inflated the balloon, the patient would have ST elevation and drop in pressures. Even though he was on ECMO, we did not want him to fibrillate and worsen the scenario. So we kept the inflations to be brief and gave the heart to recover from the ischemia, and then did it very measured way. We thought we could try the stent after the second balloon, but it would not track because of the calcium. Even though it was not circumferential, in certain areas it was more than 180 degrees. So used a cutting balloon Wolverine, and then after that the cutting balloon was given up to the LED ostial LM ostial, left main ostium, and subsequently could track the stent. So this was IVAS run after that. The IVAS could track smoothly. Then we took the first distal stent and then deployed it. And then with the IVAS confirmed that there was no edge dissection, because it looks very lot of step down and a lot of vasospasm. So we had to confirm that there was no distal dissection. So I checked with the IVAS and made sure there was no distal dissection. And then the proximal LED was tented with a 3 into uh, 23. The option was to take a 3.5 and then blow up to 4, or a 3. We felt that the mid LED was only 3, so we would take a 3, and took a 3 into 23 and covered it up to the ostium, checked it in the LAO cranial view and positioned it. And the flow was looking okay. And post dilated it with a 4 into 8 pod balloon. And now after that, when we took the check shot, you can see there seemed to be some haziness in the middle of the LM. You can see in this clearly. There's some haziness. It's almost like some struts are absent in the middle. So first of all, dilated it with a balloon again, and then checked it with an IVAS. Uh, then I was showed that there was a stent fracture, that over that calcium spicule which had produced a uh, stent fracture. So subsequently covered it up with a 3.5 into 12 stent, and this was the final result. Have the discussion now.
Excellent, Asha. And a very good save and very, well done. Do you have pictures of that IVA's stent fracture?
Yes, ma'am. There was a stent fracture in the iris. There was
Okay.
some gap, like there was some haziness, there was some disruption, like there seemed to be some slight doubt, but we didn't want to take any chances because this is the highest of risk patients. There seemed to be a little disruption, like there was a gap there, so covered it up with another stent.
I have another doubt. See, if
Yeah.
we would have done on day one, let's say, could we have got away with an impella and finished it?
No,
Because
his
the patients.
transfusions were not holding at all.
Okay, okay,
Both a combination of circulatory compromise and respiratory. His
okay.
saturations were dipping like anything. It was just going down and down. His sats were. The main issue
Mhm.
was we were not able to ventilate him adequately with even the best of
Yeah,
ventilating settings. So since his oxygen levels were not holding up, doing anything at that time would have been detrimental.
okay.
Three important points here to take. One is ECMO is initiated when the heart is recoverable. So it should be a reversible thing. ECMO is only a supported device. That one have to be very clear. Or else it should be initiated as a bridge to transplantation. There should be an opt out when you initiate the ECMO. That is the first point. Second is ECMO is very useful when you initiate before the multi-organ sets in. So as in this case, the patient are showing a decreased urine output and the creatinine is not that bad, around 2.4 only. So we initiate the ECMO, so we are able to give this result. Sometimes we will be called when the creatinine is somewhere around 6 or so, where liver enzymes should be around 8,000 or 10,000. Those cases and all, the results are not that good. So timing of initiation is very good, very important, and it should be like before the multi-organ failure sets in. Third important point is once the ECMO has initiated, one is not supposed to relax. As Dr. Asha Mahilamaran did, we need to see how we can recover the heart. Get the patient to the cath lab, do the stenting, and give the blood flow to the required muscles and revive it back. Then only we can remove the ECMO. ECMO is not without complication. It has got its own like bleeding and infection complication. So we have to remove it as quickly as possible, as done in this case. So these are three important points. I hope you all know that left main stenosis, we are giving backup for backup ECMO for the left main stenosis patients, especially they have a right coronary artery disease also. So we place a four French sheath on the femoral artery and femoral vein, and the cardiologist will do the stenting. If at all the patient is going to have any issues in the hemodynamics or so, then we'll place the guide wire and then remove the sheath and place the cannula and go on ECMO and support the ECMO, and they will proceed with the left main stenting. That also we have done here.
It was a very difficult and very challenging case and very beautifully managed by both by Asha ma'am and Madhun sir, because I think it was a proper heart team approach done in this case, because patient was collapsing and with such bad parameters. Very well done. Only issue, ma'am, I think that was very well, that LAD was showing diffuse disease.
Yes.
And there was, the stent fracture, like I had this with Sujata ma'am, sorry, ma'am also, that the stent fracture which was seen on this, so how sure it was not some calcium spicule or something, or is this haziness is not related to the calcium
Uh,
perfusion there?
So maybe I can show you again the IVIS run. So the IVIS run clearly showed that there was some disruption. So that
Okay.
is why we
So
went ahead.
how many stats you found that there was disruption in this case? Because we usually don't very frequently see them in the IVS.
Uh, just one or two strengths. There was also overlap. Dr. Vijay Kumar, who's the imaging expert, he was also around. So we checked with him also. So he also felt that it was a stent fracture, better not to leave it alone like that and cover it up with another stent. So we went ahead and put another stent. So we had the doubt, but there was definite multiple views, there was definite gap there. It was not looking very uniform. And on the IVAS also there was some overlap of stent struts, like something was abnormal in that particular point. So it was appearing like a stent fracture or a longitudinal deformation. Something was wrong there. So couldn't leave it alone in the left main like that. And so fixed it with another.
Yeah, Asha, I think
One question, sorry.
Yes, yes, Dr. Satya.
Yeah, Asha, excellent case and excellent timing of putting ECMO and managing the patient well. I'm just getting a bit greedy, you know. When a patient of multivessel coronary artery disease on ECMO, why not
Which one
complete the
is
revascularization?
RCA also? Uh,
I said, why not complete the revascularization when the
Yes.
patient is on
Uh,
ECMO?
Number one point, the RCA was not extremely critical, and the contrast load we need to manage, and because he was going in for worsening renal scenario, so increasing the contrast load will not help him. It was a good flowing vessel, and RCA. It's not like 90% or something like that. So I didn't think that it will make a difference to the patient's outcomes. The main priority was get him out to safety. He's a 47-year-old, and the wife was literally crying, and we had to do everything to save him, to live another day, and we can always call him back and do it. And that's the reason I did not feel very greedy and go ahead and fix the RCA. Even the PLV has a lesion. So when you do, you can do a complete job later on in a more comfortable way about 3 months later. And at that time, you can also evaluate your LM stent. So that was the plan, because if the RCA was critical, I would have definitely done. But that's not contributing to his ischemia. So better not to touch it was the plan.
Thank you. So, ma'am, a theoretical question. I think I think ECMO really helped this case. Okay, my question to Dr. Madan also, and Dr. Ma'am also. Uh, with this present of the ECLS trial, ECLS shock in ESC, do you think that because the ECMO didn't show any benefit for these in cardiogenic shock in acute MI patients and mortality term, so will it change in our practice, or will the selection criteria or something we have to be
Yeah,
more
I
careful?
had put a few slides on ECLS shock trial, but I did not present them. Yes, the ECLS shock trial did not show outcome differences at 30 days between ECMO, mainly because of the bleeding complications and the peripheral vascular complications. But in terms of ischemic outcomes, it was better. If you can see, what is better, slightly favoring ECMO, it was there in the chart. So probably ECMO is better in certain scenarios. Uh, and that was an all-comer shock from class C to E. So we are talking about worsening D1 who is going to E. So this is a different subset. And in fact, the editorial itself says that based on this trial does not tell us about all patients who need or need not be put on ECMO. Definitely, there are going to be patients who will benefit from ECMO, and we need to choose the patients wisely and reserve it for the ones who really need it. And I think that is what we have done in our case. This was a patient with both a compromise of the circulatory and respiratory systems. The saturation was not holding, the lungs were extremely bad, not clearing after adequate amount of furosemide and support, ventilatory support. If you see, many of our when pulmonary edema will clear within 2-3 hours of ventilation and Lasix, it will clear after NTG support and everything. It will clear quickly. But this patient overnight, around 1:30, he was intubated. When I saw him around 6:37 in the morning, he was going down, and his X-ray was even worse, and he was pouring out secretions, and it was all choking. That is why we thought we will call in
I
the
agree, ma'am.
critical care
This was
group
the ideal case for. I
who,
agree, ma'am.
who
This was the
will
ideal
come
case for
and tell us
VDA ECMO.
whether they can do anything else to improve his ventilation. When they said they cannot do anything in terms of improvement of his ventilation, that is the point when we considered ECMO as a combined decision, and then called Madan and team.
yeah,
ECMO has got
trials
a
are
different
all
role in
comer.
these sets of patients for sure, because after initiating only we don't know which way to go ahead, like whether those vessels are revascularizable or not, we don't know. So it's only, as Yashwant presented, is only for a decision making. Like we initiated the ECMO, stabilized, and then studied the thing. So apart from the ECMO, there is no way we can would have surveyed this patient. So after while we are doing the angio, if there is no any graftable thing or else stentable vessels or so, then this ECMO would have been supported, and if the patient is not recoverable, would have been bridged to transplantation if the patient, other people are agreeing. So ECMO has got a definite role in this subset of patients where the lesion, the underlying disease is reversible, or else we have an option for transplantation.
Yeah, so you won't have been able to do the revascularization without the ECMO.
Yeah,
Right,
absolutely. He wouldn't
so
have
that's
tolerated. Even with
one
the
thing.
ECMO, for every balloon inflation, he was dropping his pressures. His ST was going up. In fact, we had to give time for the heart to recover every time and then only go ahead.
Yeah.
Yeah, I agree. When this was like the ideal case for it, my only question
Yeah,
was like maybe we had the patient selection with this ECLS
yeah.
shock trial. Now the patient selection will be now more refined. Right? This was the ideal case because he was lungs were getting involved, his was cardiogenic shock, his multi-organ failure. So the selection for ECMO with these patients have to be now rather going for all coming for cardiogenic shock should not go for ECMO. What that trial ECLS also showed that this the breathing complication increases. But this was the ideal case for this ECMO.
Things are very clear. Like you have to do all the conventional methods to stabilize the patient. Only if all the conventional method fails, you need to consider ECMO, because ECMO has got its own complication, like bleeding and infection. So try all the conventional methods. If those things fails, then before multi-organ failure sets in, you have to consider the ECMO. That's what Dr. Asha Mahilamaran did.
Yeah, in the recently concluded Sky Meet, Dr. Dagubati was very strongly saying that the way we say time to balloon, we should also say time to MCS. We should be very quick and select our cases to give MCS. If you don't initiate early, the patient goes into a very critical cycle of cardiogenic shock, and from that he doesn't come out. So if you initiate early, you salvage more. And I think because of this, there are, the NHS has a good ECMO team. US is developing a good ECMO team, and in our own country, we all are having ECMO teams. So I think time will tell us, and Protect 4 trial will tell us whether all these MCS are going to prolong life and improve mortality in these cardiogenic shocks. So I think we have to wait and watch for more data. But in the meantime, we should select out our cases and initiate early, is what I think.
Yeah.
I agree.
So, any more doubts? Anybody else wants to comment?
Good evening, Ivinkar madams. Asha madam, it was a very nice case. I am Dr. Selvarani from Madurai.
Yeah, we know you. Ma'am, go ahead.
Yes, yes, madam. That time to MCS, it was very much stressed in the SCOI conference. I was there also. I attended that conference, and this is a very ideal case. And the time delay has to be very short. The time taken to go for escalation, they insist that it should be less than 1 hour. It is not seeing the case in the night, and morning you have to go for the escalation of the circulatory support. That's what it was insisted. Absolutely, we don't have any experience being in a government medical college. We don't have ECMO, but it was a very nice opportunity to. One more doubt: the vascular access. Do you use suture or any use of perclose device, madam?
No, we put it by percutaneous technique. We don't use this devices to close and all. While removing, we just compress the venous system, the vein part we compress. The artery part, we get into the theater and then close. Unlike the cath lab, what you do for your TAVI and other things, we can't use a closure device here, because after 3 to 4 days time, the edges of the wound created in the artery will be hard and it will be difficult for you to close during this using this device. So some centers are doing that, but chance of pseudo-aneurysm are quite high. So rather, what we prefer is arterial-wise suturing directly. You open the femoral artery and then remove the cannula and suture the artery under vision. Also, we can do the embolectomy also because we are leaving the cannula for long. So chance of clot formation is also there. So we remove it and pass a phagocytic catheter, remove all the clots, and then suture it. Being a surgeon, that is a very, very easiest part. So we don't mind.
Thank you for the excellent case. Thank you, madam, for excellent presentation.
So I think if there are no more questions and doubts, I would like to congratulate Asha and the team from Apollo for pulling off a miracle indeed. So, I think the team approach which Asha has time and again stressed has helped you save this patient. I thank all of you for this wonderful presentation, and I thank everybody for listening, for tuning in. Thank you. Thank you, Asha.
Thank you, ma'am. Thank you.
Thank you.
Thank you.